In this lecture, we will discuss about the cardiac cycle, cardiac action potential, and the conduction system of the heart. First, the cardiac cycle. Cardiac cycle consists of all events occurring in the heart during a systole and the following diastole. Clinically, systole starts from the first heart sound and ends at the onset of the second heart sound. Diastole is between the second heart sound and the next first heart sound. Typically, a cardiac cycle lasts 0.8 seconds, which corresponds to a heart rate of 75 per minute. Opening and closing of the valves. The sequence follows this dictum. Right-sided valves open first and close late. So if you are starting with systole, mitral valve closes at the onset of systole, followed by the tricuspid valve. This gives the M1-T1 sequence when there is a split first heart sound. The interval after the atrioventricular valve closure and the opening of the semilunar valves constitute the isovolumetric contraction time. Next, the pulmonary valve opens, followed by the aortic valve. At the end of systole, aortic valve will close first and pulmonary valve the next, giving the A2-P2 sequence for a split second heart sound. The interval between the closure of the semilunar valve and the opening of the atrioventricular valves constitute the isovolumetric relaxation time. This is followed by the opening of the tricuspid and mitral valves in sequence. Phases of the cardiac cycle. Phases of the cardiac cycle are classically described in relation to the Vickers diagram, which incorporates drawing of the phonocardiogram, electrocardiogram, pressure tracings of the atrium and ventricle, aorta, as well as ventricular volume curve. The diagram has been in use over a century, with the initial publication by Carl Vickers in 1915. Isovolumic contraction phase. Isovolumic contraction phase starts at the peak of the QRS complex in the ECG. As soon as the left ventricular pressure starts rising, the mitral valve closes. After a short while, when the left ventricular pressure becomes more than that of the aortic diastolic pressure, the aortic valve opens. The period during which both mitral and aortic valves are closed and the ventricle is in systole is known as isovolumic contraction phase. The volume of the ventricle does not change during this phase. First heart sound is heard when the mitral valve closes at the onset of the isovolumic contraction phase. Ejection phase. The blood is ejected into the aorta once the aortic valve opens. After an initial period of rapid ejection, when the ventricle continues to contract, there is a period of reduced ejection when the ventricle starts relaxing. The ejection phase ends when the aortic valve closes. This event is marked by the second heart sound. Isovolumic relaxation phase starts with the closure of the aortic valve and ends with the opening of the mitral valve. IVRT can be measured by Doppler echocardiography using mitral and aortic flows. IVRT is measured as the interval from the end of the aortic flow to the beginning of the mitral flow. Rapid inflow phase. Initial part of the diastole in which there is a rapid inflow of blood into the ventricle is known as rapid inflow phase. It ends with the third heart sound if one is present. Ventricular volume rises steeply in the initial part of this phase. Next phase in diastole is the diastasis, during which there is very little change in the ventricular volume and there is almost equalization of ventricular and atrial pressures. In mitral stenosis, diastasis is absent as there is a constant gradient across the mitral valve. Towards the end of diastole, there is a further increase in atrial and ventricular pressures and ventricular volumes with atrial contraction. This is how atria act as a booster for ventricular filling. This is the time of pre-systolic accentuation of the murmur in mitral stenosis due to the enhanced flow across the mitral valve. Naturally, this accentuation is absent in atrial fibrillation when there is no organized atrial contraction. Electrical systole of the heart. With respect to the ECG, systole starts at the peak of the QRS, accounting for the small initial electromechanical delay. Systole ends at the end of the T waves. So both ventricular depolarization, except a small initial portion, and repolarization is complete during systole. Now we move on to the cardiac action potential. Cardiac action potential. The typically described cardiac action potential is that of the myocardial cell. Action potential of tissues like sinus node will be different and characterized by diastolic depolarization, which contributes to the automaticity of the sinus node. Cardiac action potential is different from the surface ECG, which represents the sum total of all electrical activity of the heart as recorded from the body surface. Myocardial action potential is recorded with intracellular electrode under experimental conditions. The action potential has total of 5 phases. This is the diagrammatic representation of the action potential of the myocardial cell. Initial rapid upstroke is the phase 0, and next rapid downslope is phase 1. It is followed by a plateau phase known as phase 2, and a third phase is a slow decline, and a fourth phase is in diastole, which is back to the baseline. Phase 0 is the initial phase of rapid depolarization, in which the intracellular voltage rises from about -90 millivolts to about 20 millivolts. The peak rate of rise is called Vmax. It is due to the rapid influx of sodium ions through the open sodium channels. Phase 1 is a rapid initial fall in intracellular voltage due to opening of potassium channels. This part is mediated by the transient outward current known as ITO. In phase 3, calcium channels close while potassium channels remain open till the intracellular voltage reaches the baseline value of -90 millivolt. The potassium channels active in this phase are IKS, the slow component of delayed rectifier current, IKR, the rapid component of delayed rectifier current, and IK1, the inward rectifier current. Phase 4 is the resting membrane potential, which is maintained stable at -90 millivolts by the potassium currents IK1. Sodium and calcium channels are closed during phase 4. This is the diagrammatic representation of the action potential of pacemaker cells. It shows the diastolic depolarization, which is responsible for the triggering of the next action potential. Action potential of the pacemaker cell is different from that of the ventricular myocardial cell. It is characterized by lower slope of phase 0 with a lower Vmax and the presence of diastolic depolarization mediated by the funny current, which is also known as pacemaker current. Funny current is through the hyperpolarization activated cyclic nucleotide gated HCN channels and is a mixture of sodium and potassium currents. With sympathetic stimulation, the funny current and the slope of the diastolic depolarization increases and heart rate increases. The slope of diastolic depolarization decreases with parasympathetic stimulation and heart rate decreases. The depolarization phase is mainly due to L-type calcium channels. During repolarization, potassium channels open and calcium channels close. There is some contribution to the diastolic depolarization phase by T-type calcium channels. Now we will move on to the conduction system of the heart. The conduction system of the heart consists of specialized conduction tissue. The components of the conduction system are sinoatrial node, internodal pathways, atrioventricular node, bundle of His, bundle branches, and Purkinje fibres. Sinoatrial node is situated in the upper part of the right atrium near the opening of the superior vena cava. It is a subepicardial structure. Sinoatrial node is a natural pacemaker of the heart with highest automaticity among the specialized conduction tissue. The diastolic depolarization in the sinus node is responsible for the automaticity and is mediated by the funny current. The sinus node has both sympathetic and parasympathetic innervation, which modulates the heart rate. The heart rate after total sympathetic and parasympathetic blockade is known as the intrinsic heart rate. There are three internodal pathways: the posterior tract named after Thorel, middle tract named after Wengebach, and an anterior tract which gives off the Bachmann's bundle carrying impulses to the left atrium. Though these three tracts have been discussed, they are not clear-cut anatomical bundles which can be easily localized like the bundle of His and its branches. They are microscopically identifiable, preferentially oriented fibers. Many have even doubted their presence and considered that internodal conduction is through the atrial myocardium. Atrioventricular node is situated in the lower part of the right atrium at the apex of the Koch's triangle, formed by the ostium of the coronary sinus, tendon of Todaro, and the septal part of the tricuspid annulus. It is a subendocardial structure, unlike the sinoatrial node, which is a subepicardial structure. An important role of the AV node is to delay the signals coming from the SA node till the atrial contraction is over. The AV delay ensures that atrial and ventricular contractions are sequential rather than simultaneous, thereby allowing the atrial booster action for ventricular filling during the terminal part of ventricular diastole. It can also act as a subsidiary pacemaker of the heart if the sinoatrial node were to fail, though the automaticity of the AV node is less than that of the SA node. The AV node has a slow pathway and a fast pathway. It is known as dual AV nodal physiology. The fast pathway is anterior, has a higher conduction velocity but a longer refractory period. The slow pathway is posterior, has a slower conduction velocity but a shorter refractory period. Dual pathway has a role in the genesis of AV nodal reentrant tachycardia. The bundle of His arises from the inferior border of the AV node and enters the upper part of the interventricular septum. Signals from the bundle of His can be recorded using intracardiac electrodes, and it is known as His bundle electrogram. The fibers destined for the bundle branches are segregated within the bundle of His even before its actual division. The bundle of His divides into left and right branches destined for the corresponding ventricles. Part of the right bundle travels through the moderator band in the right ventricle. Left bundle branch further divides into a left anterior fascicle and a left posterior fascicle. Left anterior fascicle is thin while posterior fascicle is thicker and broader, with a dual blood supply so that it is seldom involved in disease processes. Some authors describe an additional left septal fascicle. Purkinje fibers are specialized conduction cells which ramify within the myocardium and conduct the impulses from the bundle branches throughout the myocardium. It is finally the Purkinje fibers which carry the signals from the SA node to the myocardium for initiating excitation, contraction, coupling. Please subscribe to this channel for future updates. Thank you.